Welcome to today's webinar with the Accountable Care Learning Collaborative. My name is Scott Hammer, and I'll be moderating today's call on the Medicare ACO results from 2015. We're excited about today's presentation, and in particular the opportunity to hear from Dr. David Muhlestein, who will share insights about this round of ACO results. Just a few housekeeping items that I want to cover before we get started. To minimize feedback, please mute your line. If you are dialed in, please use your phone's mute feature. If you are using your computer only, click the microphone icon. If you are using both a phone and a computer, it is best to select the telephone option under audio in the GoToWebinar window, then mute your phone. There should be opportunities for questions, so please submit them using the questions box of the GoToWebinar window. I also want to share a few announcements about the ACLC before we get started. We're coming up on a big week for the ACLC, and we wanted to give you a heads up on what is upcoming. First, early next week, we'll be releasing our 7 workgroup papers that identify the core competencies risk-bearing providers need. We're working on a big press strategy for that opportunity. The release will be in the form of a call for collaborative action, and we're simultaneously presenting to the broader healthcare community around what we've done and asking them to contribute their knowledge to the work. We'll send you the final documents and press kits that you can use with your own organizations and sharing with others. Second, work groups are meeting again this month beginning next week. You should have received calendar invitations already. They will be discussing the publications and the work ahead, and preparing for the in-person meeting on October 18th and 19th in DC. If you are not on a work group and you wish to join one, please email us and we can arrange that for you. Lastly, we'll be sending out more information next week about the next phase of the ACLC and what we can do together. So expect to see an email coming from our co-chairs, Governor Mike Leavitt and Dr. Mark McClellan. More of this will be discussed on October 18th and 19th in DC, so please register for that event if you haven't already. For today, we'll plan to cover 2 items. After introducing Dr. Muhlestein, we'll hear an update about the MACRA Pick Your Pace announcement from CMS, understanding what that means and why it's important. And then Dr. Muhlestein will present on his recent health affairs publication, Medicare ACO Results from 2015, The Journey to Better Quality and Lower Costs. And again, we should have time for questions during the session, so we'll take questions from the audience as we go along. I wanted to introduce Dr. David Muhlestein. We're excited to have him with us to present. Dr. Muhlestein is the preeminent researcher on ACOs in the country. He currently serves as Vice President of Research at Leavitt Partners and is a visiting fellow from ACLC. David is an expert in using policy analysis, predictive modeling, and applied analytics to understand the evolving healthcare landscape. He earned his doctorate in health services management and policy, a JD, an MHA, and MS from the Ohio State University. He also earned a BA from Brigham Young University. He also serves as adjunct assistant professor for the Dartmouth Institute. David, it's great to have you with us. I'll turn the time over to you. Thank you so much.
Thanks, Scott, and it's great to talk through what we've learned from the early ACO results as well as this brief macro update. So the big announcement last week was that Andy Slavitt wrote a blog post for CMS saying that there was a new opportunity for people to slow step their way into the macro program. One of the big concerns was that due to the timing where the performance year was 2017 that was going to lead to payment adjustments for 2019, that with the final regulations not even coming out until the latter half of this year, that providers were not going to be prepared for reporting their quality results, or it wouldn't necessarily be fair for them to be judged on them given the lack of time for preparation. And so this last week they announced that there would be 4 options for ACOs going into, or for organizations going into 2017. The first is that they can just test the quality payment program. And what this means is they're able to simply be reporting on their quality goals. They're not going to be judged based on them, so there's not an upside opportunity, but there's also not a downside opportunity. Second option is to participate for just a portion of the year. So they might not be ready January 1st, but they may be ready by the second half of the year. And so organizations would be eligible for bonus payments based on their performance for that portion of the year. They could also say that they're ready now and they're going to jump in and they're going to report on their different quality programs or for their quality measurements for the entire calendar year, and that would determine whether they received a bonus or a penalty under the MIPS program. The fourth option, which continues to exist, is you can completely avoid the quality payment program by qualifying as an advanced APM, and this is for two-sided risk ACOs as well as a handful of other demonstration programs. And so organizations have more flexibility, and I think this was largely recognized as an opportunity for people to begin to experiment with this program in 2017, given that the final rules are not out. One important announcement that they did make in this blog is that the final rules should come out by November the 1st, which means that we should have at least 2 months before the end of the year to study and evaluate them. And the ACLC will do a full in-depth analysis of those final rules and provide feedback to members. I'm now going to talk a little bit about the shared savings results. As you know, the shared savings program is the largest single ACO program, and it is also the only program that has a large number of organizations that are participating with comparable reporting and measurement responsibilities. And this allows us to see variation among the organizations and start to identify high performers and also organizations that are doing better or worse, maybe for demographic or other factors. And this was published last week on the Health Affairs blog, and so if you want access to that, it's available, and I believe that you've seen it in an email contact or an email. But we encourage you to read that, also provide feedback, and if you have recommendations or suggestions about further work that can be done, please provide that feedback as we're anxious to hear from you. Also, as we're going through, please ask questions in the window, and we will try to answer them as we're going through, or we'll come back to them at the end of the presentation. We're going to start today by just giving an overview of the program. So in 2015, there were 392 ACOs that were participating, and they had entered into the program in one of 4 different waves. They started in April or July of 2013, or January of 2014, or January of 2015. Of those, only 3 chose Track 2 with a two-sided risk. Most ACOs, as you are aware, are much more inclined to go for upside only, where there is a less opportunity for savings. It's a smaller percentage of the savings, but there's also eliminating that downside risk as people are experimenting with them. I'll also note that the average quality score was 91%. There is a caveat to that score, and that is that all of the ACOs that are in the first year of the program, they get full points by just reporting their measures. And so about a third of the ACOs came from that final 2015 cohort, and so that weights the score up a little bit higher. But going on, we're going to start looking at some of the results as they relate to quality. And what you see here on the vertical axis is the percent of savings or the percent of losses. So the top ACOs saved up to 20% relative to the benchmark, and the worst performers lost 20% relative to their benchmark. On the horizontal axis, you see their aggregate quality score. For this one, we've excluded those that just had the 100% based on reporting for the 2015 ACOs. But what you see here is a lack of correlation between cost and quality. One of the key tenets of the triple aim is that we want to see an improvement in the cost of care, but that's driven by the improvement in the quality of care. You don't have to be a statistician to see that there's not a strong correlation here. And what we're seeing is that there are other ways that people are saving money in the short term. We're also seeing that people are able to improve quality in the short term, but they don't necessarily go together. You can improve your quality or you can improve your cost. You may do both, but you don't have to. Another thing to point out is that the performance is very mixed. When you're just looking at the vertical axis, you're seeing that there are a lot of ACOs that have done well, and in fact, the centroid of this, if you kind of get the weighted average, it's on the better side. So people tend to be saving money, but there are a lot that are losing money. Some are losing a little bit, some are losing a lot relative to those benchmarks, and so the performance scores are really all across the board right now. what we need to derive from this is recognize those that are performing well, understand what is driving that high performance, and then take those best practices and those learnings and then disseminate them more broadly. And that's really what we're trying to accomplish over the next year with the Accountable Care Learning Collaborative, is learning how those high-performing organizations are performing, take those best practices and help to disseminate them so that hopefully those poor performers can move into that upper half of the chart. As we look at the specific quality measures, you'll see that there is very little difference between those that received shared savings and those that did not receive shared savings. Those that are you see in the blue received the bonus payment, and those that are in the gray did not. By and large, there was very little difference between the different organizations. There were a handful of measures such as screening for falls or weight screening or controlling for high blood pressure that ACOs did better on. ACOs that qualified for savings did better on, but at the same token, there were a handful of ones that the worst performing ACOs did, such as the timely care and appointments and access to information under the patient and caregiver experience. The takeaway from this is that the quality performance is not largely dictating the performance or the performance on individual scores. And so we're seeing kind of across the board ACOs that do better or do worse, but by and large, those that are receiving shared savings and those that are not tend to be doing relatively similarly on their quality scores. One of the things to keep in mind is that these quality scores are the average across the organizations, and they also, though, run from a potential of 0 all the way up to 100. And that's when you look at where the ACOs are relative to their peers. Almost universally, they're coming at above average. So the organizations that are participating in this are doing better than the non-ACOs out there. There are a handful where there is a very low performance score, and there may be issues with the measurement that are driving that. But by and large, ACOs are better than average for their quality measures. Now, this is the metric that people are really interested in, which is how does the benchmark influence the savings? We're going to look at this at a few different ways, and at the highest level, we're just trying to evaluate how the benchmark or the average benchmark score versus the expenditures by beneficiary. And the blue is what the benchmark was, the gray is what the actual score was, and so those that received savings tended to have almost a $2,000 higher benchmark score to begin with. So while they were able to provide an actual expenditure that was much lower, it actually turns out that their average expenditure was higher than those that did not receive those shared savings. And so when you're just looking at it in the aggregate, you see that ACOs that shared savings did this largely by starting at a higher benchmark. Now, that's not universally the case, and we'll look at some others to view that, but ACOs that saw savings tended to start much higher with a benchmark. And the best analogy here is looking at where there's room for improvement. If you are trying to improve your time running a mile, and if you're running a 10-minute mile, there's a lot more room for improvement than if you're already running a 4-minute mile. And so these ACOs that are starting with that higher score have a lot more opportunity to decrease those costs over time. Now, when we look at it based on quintile, we're able to see kind of a different story. Again, this is taking all of the ACOs and we just broke them down into quintiles based on their benchmark score, and then we calculated the percent that qualified for shared savings. When you look at those that are in the higher quintiles on the fourth and fifth columns, you see that almost 50% of these organizations qualified for these savings. When you look at the lower quintiles, the first, second, and third, you see that a very small percentage of them qualified for these savings. And so the higher the benchmark, the more opportunity there is, even when you're starting to break it down by these quintiles. But what's really interesting is that even in these lowest quintiles, those that had lower than $8,500 per member per year, there were a significant number of ACOs that were able to see these savings. About 15% of these were able to qualify for these savings. So just while it's a lower bar for higher performing organizations, or those that come with those that come in with a higher benchmark organizations, there's more opportunity for them to see savings. We are seeing meaningful activity at these lower levels. So one of the key things that we need to identify is where is there still opportunities to achieve savings once you've already eliminated some of these higher costs. And that's something that we really want to look at from the ACLC perspective, is how do these lower benchmark organizations continue to see savings against their benchmark year over year. Another major factor that influences the ability to see savings is the time in the program. And what this is broken down is the years in the program, and this is based on the cohorts. So those that have been in the program for 1 year are those that joined very early on in January of 2015. And those at the very end joined in April of 2013. What you see is that those that have been in the program longer tend to do better. And that's really matters because when we talk about healthcare delivery, we often talk about payment reform. And ACOs are a form of payment reform. All of the advanced alternative payment models, bundled payments, all of these risk-based arrangements are really trying to drive a change in behavior based on the payments that are coming to the organization. But that's just the first phase. The first phase is to pay people differently, to change their incentives so that they have an opportunity to change how they're delivering care, and the incentives will influence that. Well, it's important to get those payment models right. Those delivery models are hard, they're complicated, and they take a long time to figure out. Just because you're paying somebody differently doesn't mean that in year one they have their technology in place, their EMRs and their population management systems in place. They don't necessarily have all of their agreements with affiliated providers. They don't have all of their physicians on board. They don't have their care coordination programs up and running. It takes time and effort to really figure out the delivery reform portion of this. The good thing that we're seeing is that over time, as people have spent more time in the program, there's more of an opportunity for them to figure this out. And those that joined in the very first cohort in April of 2013, almost 50, or a little over 50% of them have qualified for these shared savings. And so there's optimism as we see that this can be figured out. It's going to take time, but it can be figured out over time. Another important thing is looking at who is being successful based on the type of organization. So we put these into 3 groups: hospital system-led, physician group-led, and an integrated system that has both hospitals and physician groups that are working together on this. By and large, we see, just looking at this, is that organizations that had physicians a part of it, either as an integrated or just as a standalone physician group, did better. But there's a really important caveat from this, and this is where we adjusted for the time in the program and the benchmark. When we did that adjustment, it turned out that there was no difference based on these structural differences from these in terms of their raw ability to see savings. And why is that? And a few ideas is that there are different opportunities for different organizations to see savings. Now, when we talk about physician groups, we think that physicians are very well situated to see savings because they're going to provide more outpatient care, so they'll be paid more in the interim, and they'll also be able to avoid hospitalizations, and then they can see the benefit from avoiding those hospitalizations in the long term. That certainly is happening, and some of the highest performing organizations have talked about how that was really their model, is trying to avoid those hospitalizations. But just because you might still be dependent upon hospital revenue doesn't mean there's not an opportunity to improve the quality for your population and to lower that cost at the same time. And so hospitals, for example, have been, where they might not have tried to reduce their inpatient admissions, they might have done a lot to address their post-acute care strategy and making sure that people are spending the appropriate amount of time in skilled nursing facilities or only using the necessary home health after they've been discharged. So organizations from all types and backgrounds have the opportunity to see savings, and that's an important takeaway. What's interesting here is trying to just look at a geographic analysis and saying what's going on in different parts of the country. This is census regions, Midwest, Northeast, South, and the West. And the thing that jumps out is that the South has tended to do better than the other regions. A higher percentage of the organizations in the South have seen savings. 2 things that I'll point out. First is that there are more organizations that have joined the Shared Savings Program in the South than any of the other regions. So there's a larger volume of organizations, but even when you move it down to a percent, they're still seeing more better outcomes. The second is that this difference is still significant even after adjusting for time in the program and the benchmark. We're not exactly sure why the South has seen better outcomes. You'd think that by and large the South tended to have higher benchmarks, but even adjusting for those benchmarks, organizations in the South have seen better outcomes or a higher percent of savings. And so more work is needed to be done to start to evaluate this and understand what differences might be playing out in different regions of the country. This map is showing the geographic variation, and what we're trying to get at here is just say, in the aggregate, what is the average performance score for ACOs? What is the average percent savings? And what we're seeing is that it varies across the country. You do see that there are more of the green states that come from the South, and that there are more red states in the West and the North Central. But it's really just to show that there is variation. And so sometimes there are dozens of ACOs within these markets, and other times there are only a handful of them that are representing the total savings or losses within that. But there's a lot of variation across the country. What we want to do is identify the high-performing variation and see those that are positive outliers and take the best practices from that going forward. This next slide is trying to identify not just the average performance score, but how does this total, how does it impact the program? So what we've taken out here is taken all of the different rounds of the program, and we said, what was the net impact across all of the ACOs in each of these different groups? So if you look at the April 2012 start date ACOs, we look at that they represent 350,000 beneficiaries. Their net savings was almost 2%, which was a $72 million savings for Medicare. And what I'll mention is that this is a savings after any shared savings have been paid back to the organization. So the actual shared savings was around $140 million, but a lot of that was paid back to the ACOs because of the 50-50 shared savings split. When we look down at the total across all of the programs, there was a net loss to Medicare of $216 million, and that was 0.3 of 1%. And what this is driven by is largely the paid back savings were large enough that they offset the collective savings that the organization showed. But what we see here is that over time, the organizations that have been in there the longest are doing better. They're representing a larger net impact for Medicare. And so those that began in 2012 were those that really saw the net savings after paying out for those bonus payments. And they also represent a disproportionately small percentage of the Medicare beneficiaries. So when you stop looking at it just as the average percent that's shared in savings, and then you start looking at it as what is the total impact, the total financial impact, you really see that the longer in the program is making more of a difference than shorter time in that program. The next thing I want to talk about is looking at the performance over time. And this is looking at year performance 2013, 14, and 15. We now have 3 years worth of data. And you can see that those that began in round 1, about 30% saw savings in 2013, 35% in 14, and over 50% in 2015. We've seen that similar improvement for all of the other rounds. We've seen an increased percentage of ACOs that have been able to realize the savings. And so it's not just that we're seeing it over time that they've done well in 2015, but we've also seen that individual cohorts are improving year over year. This is really leads us to be optimistic, thinking that there is a lot of opportunities to improve over time, and that the jump that we saw for round 1 from 2014 to 2015 might also be achievable by those that have come from these other rounds. There's something really unique about the 3rd or 4th year of participating in the program, where your program, or in the ACO program, where your internal programs are really in place. You're able to see some of those differences and realize some of those benefits over time. But we're really optimistic that we'll be able to see a continued improvement of these ACO organizations over time. I'm going to summarize now with just some takeaway points. The first is that we have seen an improvement of quality. The ACOs, by and large, are doing better than non-ACOs across all Medicare programs. We've also seen that ACOs have largely done well with a 91% average quality score over time. When you look at the net impact for Medicare, it's really negligible. It's not significant, a significant difference from zero. And so the quality has been able to improve while the costs have not increased. Within that, though, we have seen organizations that have been successful, and so those that have been in the program longer are more likely to see those successes and to see those improvements. And it doesn't matter when they started in the program, we're just seeing that over time they've started to improve. One of the things we didn't show here, but was looking at the average performance by group size. And we actually found that smaller groups, those that had fewer lives, were more likely to see shared savings than those that were larger groups. And it could be an artifact of the number of ACOs, it could be random chance. It could also be that smaller organizations are able to implement their programs just a little bit faster. So not necessarily that they're going to end up at a higher place, but that they're able to implement things a little bit faster. I talked about this at the beginning, but payment reform is only part of the equation, and payment reform is largely what we talk about in policy circles, but that's not the ultimate objective. The ultimate objective is delivery reform, and that it takes time and effort to have payment reform move to that changes and the positive improvements that are realized from the delivery reform. I also just mentioned that the lack of correlation is still concerning. We would love to see that their improved financial performance is driven by improvement of quality. Instead, what we're seeing is that overall we're seeing an improvement of quality, but then those quality performance scores are not necessarily correlated with the financial performance going forward. And finally, there are opportunities for some refinements over time. That benchmarking, Medicare, CMS has already put out a revised benchmarking regulations, which we think is helpful, but there might be some more opportunities to evaluate the benchmarks, because when we saw earlier on, so much is dependent on where people are starting from, that we don't necessarily want all of the shared savings to go toward those that started with a higher benchmark, but those that started by spending more money. Where there are opportunities to really incent the high-performing providers to continue to do better and to take their best practices and sharing them. The last thing is that there's really an opportunity to create some mandatory pilot programs. Similar to what they've done with the mandatory bundled programs, it's really hard to see what population level payments can really do when it's still a completely voluntary program. And so there's some opportunity for Medicare to look towards some of these programs, not forcing people into risk beyond their ability to bear, but potentially putting people into programs that are upside only. So they don't have similar to the track one, where they don't necessarily have a risk at losing money, but there's a mandated aggregation of the total population cost so that we can see how organizations are performing. With that, that's a summary of the program, and if there are any questions that people have, I'd be happy to answer those. But if not, we can always end early. So we'll wait for just a second to see if any questions come in. But if not, we will give you just a minute back to your day, and we'll end a minute early.
David, thank you so much for being with us today. We appreciate your insights and your perspective on the results from the recent ACO 2015 information, and grateful that you were able to share these insights with us. As we're looking here, it doesn't look as though we don't have any questions, and so we will just plan to wrap up. And if you do have questions, please be sure to contact us, and we'll plan to share this information with you, and we will answer those questions as you ask us. Just so you know, an audio recording of this conference call will also be made available and will be included in our weekly news summary. The next webinar is this Friday, 2 days from now, September 16th, on the topic of care coordination, and it is titled Optimizing Care Coordination, Exploration of Methods and Leading Practices. So we look forward to having you join us for that event. If you have any questions, like I said, about the ACLC or follow-up questions about this webinar, please email members@accountablecarelc.org, and we'll be happy to address your questions. With that, thank you for joining us, and we hope that you found this presentation worthwhile and enjoyable. Have a nice day. Bye-bye.